Our lecture today will encompass medications that affect the central nervous system. We will be focusing on psychiatric medications and pain management. These categories of medications may be seen in patients in the ICU and ER as determined by patient history and as needed when intubation or ventilator management and other complex procedures come into play. Drugs that affect the central nervous system are the most widely prescribed and used medications in the United States. They are used to improve mood and decrease the perception of pain. First, let's look at how the brain is organized. The outermost layer of the brain is the cortex, which is responsible for thought, memory, self-awareness, personality, and speech. It is also important in the perception of sensation and control of body movements. The midbrain controls autonomic functions such as hormone release and immune response. The brainstem or medulla controls breathing, cardiovascular response, and alertness, and the cerebellum regulates fine motor control, such as picking up objects. The central nervous system medications we will be discussing affect neurotransmitters in specific areas of the brain. They can affect these neurotransmitters by determining how many are released, how they metabolize or reuptake, meaning the reabsorption of the neurotransmitter, or by acting on primary or modifying receptors or transport proteins. The first group of medications we will discuss are psychiatric medications. They can be further broken down into antidepressants, mood stabilizers, antipsychotics, drugs for Alzheimer's dementia, anxiolytics or anti-anxiety medications, and barbiturates and other hypnotics. Our first group is antidepressants or drugs that treat depression, which affects approximately 6% of the U.S. population and 4.4% of the population worldwide. The first line of treatment is often our SSRIs, or selective serotonin reuptake inhibitors. Medications that fall into this category are Celexa, Prozac, which is an older medication, Paxil, Zoloft, and Lexapro. Other categories of antidepressants include serotonin and norepinephrine reuptake inhibitors, such as Effexor and Cymbalta, dopamine reuptake inhibitors, Wellbutrin and Zyban, which we previously discussed as having a role in smoking cessation, tricyclic antidepressants such as Remeron, and monoamine oxidase inhibitors, or MAOIs, such as Nardil, Parnate, and Marlplan. Some herbal remedies have also been used, such as St. John's wort. Next are our mood stabilizers, which are generally used for bipolar disorder, which manifests as alternating depression and mania. Medications in this category are lithium, valproic acid, marketed as Depakote, carbamazepines, such as Tegretol, lamotrigine or Lamictal, and other antipsychotics that we will discuss in a minute. All mood stabilizers have the side effect of sedation, except lithium, which can cause tremors, slowing of thoughts, hypothyroidism, renal insufficiency, increased white blood cell count or leukocytosis, polyuria, and polydipsia or increased thirst. Antipsychotics are used to increase dopamine levels in the brain to help control patients experiencing impaired reality from schizophrenic spectrum disorders and psychosis associated with depression and mania. They include older agents such as thorazine, thioridazine, and haloperidol or Haldol, which have serious side effects such as cogwheel rigidity, which is muscular rigidity in the limbs, which elicits a ratchet-like start and stop movement, acute dystonia, which is involuntary muscle contractions that cause repetitive or twisting movements, and cholinergic side effects. The newer drugs such as risperidone or Risperdal, olanzapine or Zyprexa, and quetiapine or Seroquel have a better side effect profile. Drugs used to treat Alzheimer's dementia fall into the category of cholinesterase inhibitors and may improve cognition and early disease presentation. Side effects are mainly gastrointestinal issues. In the anti-anxiety category, we have medications that reduce anxiety and create varying degrees of amnesia. If taken with opioids, they may depress respiration. Within this category are benzodiazepines, which are used to reduce anxiety and are well suited for anesthesia induction. They are often used as induction agents in rapid sequence intubation as they prevent unpleasant recall of events, promote sleep, and relaxation. Medications in this category include alprazolam or Xanax, diazepam or Valium, lorazepam or Ativan, midazolam or Versed, and triazolam or Halcion. Overdoses can be reduced with flumazenol or romazicon. Barbiturates are the oldest class of sedative drugs and are derived from barbituric acid. They have a high degree of toxic potential as they are highly addictive and can be abused and have largely been replaced by benzodiazepines. They may be used for anesthetic induction as seen with thiopental or pentothal, thiamyol or suritol, and methotrexate or Brevital. Barbiturates used as hypnotics, meaning they induce sleep, are pentobarbital, marketed as Nimbutal, and secobarbital, marketed as Cicanel. Lastly, in this category, we have phenobarbital, which is primarily an anti-seizure medication used to prevent status epilepticus. Other sleep-inducing medications include Lunesta, Ambien, and Restoril. Pain is an unpleasant subjective experience and is considered the fifth vital sign, and therefore pain management is of the utmost importance when caring for patients. Generally, we use pain scales from 0, indicating no pain, to 10, indicating the worst imaginable pain, or from smiling to frowning to assess patients. Pain is considered both a physiological response from CNS pain receptors and an emotional response to the pain experience. In the first category of pain management, we have our nonsteroidal anti-inflammatory drugs, or NSAIDs, that relieve mild to moderate pain. Aspirin, as salicylate, falls into this category, but is associated with an increased incidence of Reye syndrome in children, and is therefore used with caution in this population. Acetaminophen, or Tylenol, has no anti-inflammatory effects, but does provide relief of mild to moderate pain, but can cause lethal hepatic necrosis in high doses. Overdose of Tylenol can be treated with oral N-acetylcysteine or Mucomyst. Our next category of pain relief is our opioid analgesics, which are derived from the opium in the poppy plant. They are used for moderate to severe pain, but are highly addictive, and withdrawal can be very painful and unpleasant. They bind to naturally occurring endorphin and enkephalin receptors. Medications in this category are morphine, codeine, fentanyl, heroin, hydrocodone, hydromorphone, oxycodone, and tramadol. They have a complex side effect profile which includes respiratory depression, constipation, nausea, and vomiting. They can also be used as an antitussive to suppress cough. For overdoses, naloxone, or Narcan as it is commonly called, is used and is now available over the counter as opioid addiction and abuse has become a public health crisis. Opioids can be given by a nurse or by a patient-controlled analgesia or PCA pump. Studies have shown the pump is better at keeping control of pain rather than trying to regain control once pain has set in. Inhalation of opioids may be used for dyspnea and advanced respiratory failure and for those with terminal cancer without lung disease. Next, we will briefly discuss local anesthetics such as lidocaine and benzocaine, as they can interrupt nerve signals that contribute to pain and can also be used to end cardiac conduction abnormalities such as ventricular tachycardia and fibrillation. Both lidocaine and benzocaine can cause methemoglobin, which causes diffuse cyanosis, and are of particular interest to respiratory therapists as they can be used as lubricants on endotracheal or bronchoscopy tubes. Lidocaine can also be instilled down the endotracheal tube as a method of administration, along with naloxone, atropine, vasopressin, and epinephrine, and can be remembered by the acronym NAVEL or NAVEL. Other medications of interest in this group of anesthetics are induction agents such as propofol, ketamine, and etomidate, which provide analgesic effects prior to medical interventions in the ICU, ER, or OR, such as intubation or conscious sedation. Close monitoring of ventilation and cardiac function are of utmost importance. The last topic we will discuss is conscious sedation and its relation to respiratory care. The goal of conscious sedation is to provide patient comfort without the loss of airway maintenance and protection. Respiratory therapists have a role in monitoring pulse oximetry and ECG monitoring, temperature maintenance, blood pressure, and ventilation, as there must be at least one person solely responsible for recording these vitals.